that what is the management of intraoperative MI. So intraoperative MI, as we have discussed, that most common occur because of the mismatch between the myocardial oxygen supply and the demand. So the management would consider stoppage of stoppage of the surgery, notify the surgeons, and to ensure that adequate oxygen going to the myocardium, we have to maintain the supply and demand ratio. We need to look into the factor which is what is causing the decreased oxygen supply to the patient. Like if patient has hypothermia, or if there is hypotension is there, or hypertension is there, so we need to consider the factor which is impairing the oxygen supply to the myocardium, is causing the increased oxygen consumption. So, because occurrence of type 1 MI is very rare, so if it occurs, most commonly the type 2 myocardial infarction occur, that will include to consider the optimization of the factors which will govern ensure the adequate oxygen supply and the demand.
So Dr. Pasha has another question. He wishes to know what is triple index.
Triple index. Triple index, ma'am.
Pasha, can you be a little more, elaborate a little more? Just type down in what context are you talking about triple index, so that we can help you better with your question there. So just type that again, and we'll come back to your question. Even I was a little confused as to what does he mean by a triple index. Um, so Dr. Deepika wishes to know if there is any preference of any muscle relaxant along with etomidate during induction. I think Dr. Deepika is talking in term of a cardiac patient. So I think whenever you're looking at any such situation, when looking at cardiac patient, you go for a drug which is most hemodynamically stable, because that is what we want along with etomidate. Would you agree with me on that, Dr. Sukyanti?
Yes, ma'am. So the agent which causes tachycardia or histamine release, they need to be avoided. We need to select muscle relaxant, which will be more kind of cardiostable, which will not cause any increase in the heart rate or blood pressure, heart rate. So histamine release is by the atracurium. So if patient is not very much do not have good LV function, so in that condition we can avoid the histamine releasing agent. We can avoid rocuronium that will cause tachycardia. So in these patient, the muscle relaxation selection is depend on these factors.
Mhm. Dr. Shruti wishes to know, it's an interesting question, that if is a preoperative cardiology consultation for fitness a must for patients with isolated diabetes or hypertension during PAC evaluation?
I don't think it is mandatory. It,
Mhm.
if patient has isolated diabetes or hypertension, and if on preoperative evaluation you are able to find that patient has very good functional capacity, it is very unlikely that patient is going to have any major adverse cardiac event perioperative period. So it is not a mandatory thing to get the preoperative cardiology consultation for fitness.
But again, there are many factors that are coming into play. You cannot have an isolated blanket statement like that. That is there a role? You have to see many other factors. Supposing you have a patient who's 80 years old and diabetic, maybe in that patient it might just be a good idea, or if doesn't have a good functional capacity. And as Dr. Sukyanti very rightly said and very wisely said, that functional capacity is your best judge. Dr. Prachi Parekh wants to know if there is any role of bridging therapy with heparin if the patient is on anticoagulation. Dear Prachi, first we need to know as to what kind of anticoagulation the patient is on. Is the patient on warfarin? If you buy anticoagulation, you need a dual antiplatelet therapy. So first of all, kindly just clarify what exactly. Write in the chat box what you're looking at, and we shall come back to you on that, because the recommendations are different for both. Dr. Susmita wants to know if a patient develops new onset LBB intraoperatively or immediate postoperative period, what will be the line of management? Very good question, Dr. Susmita.
Yeah.
Dr. Chanti, would you like to answer that?
Yes, ma'am. New onset LBB is an indication that patient is sustaining myocardial ischemia. So we need to find out, we have to collaborate this ECG finding along with the other factors. If patient is in post-operative period, we need to see whether the patient has any symptoms for that or not, and we need to get the biomarkers for cardiac myoischemia to be done. Because new a patient does not have LBB previously and has now developed new onset, it could be an indicator of the myocardial ischemia. So clinical judgment, clinical symptoms need to be considered, the biomarkers need to be sent, and we have to check their values. And while these are done, the patient need to be optimized, by meaning that the the factors which causes the myocardial oxygen demand and supply, they need to be optimized, while the we can decide on whether the patient has sustained myocardial ischemia or not.
Thank you, Dr. Sukyanti. Dr. Prachi has just clarified. She wants to know if there is any role of bridging therapy with heparin if the patient is on dual antiplatelet drugs.
The guidelines are not very clear. In fact, if the patient has dual antiplatelet drugs, the mechanism of action of the platelet and the heparin, they are very different. So to prevent stent thrombosis, if at all patient is at the, it will be decided by the cardiologist whether if the patient has is at the very high risk of the stent thrombosis, then some says that the bridging therapy has some role. Bridging, but for the bridging therapy, not heparin, the newer antiplatelet drugs which have the shorter lifespan, like the GP23 inhibitors,
Yes,
tyrofibin and
right.
abeximab, they have
Yes,
been recommended that they can be used as in bridging therapy. But
yes,
heparin has entirely different action that cannot be used as a bridge to the antiplatelet drugs.
yes. Very well answered there. Yes, and it is not a good idea to go for heparin. Dr. Jaktaran Singh, one of our regular students, along with Dr. Prachi, they are brilliant students, Dr. Sukyanti, and I love when they interact with us. So, Dr. Jaktaran wishes to know, is resting echo really reliable than stress echocardiography? As there are certain patients whose resting echo is normal and they develop complications perioperatively. How to anticipate such an event, as stress echo is not done routinely and most of the times resting echo comes within normal limits only.
Resting echo will not be able to tell you the amount of the physiological stress that patient will be able to handle during the perioperative period. So the stress echo is always better compared to the resting echo. Resting echo, in fact, is not recommended uh, uh, if at all it is needed during the perioperative period. Uh, the stress echo that will give you kind of the stress that the patient will be able to take up. However, stress echo again is not feasible in all the patients. There are certain recommendations that we have discussed that stress echo is useful only when the patient is at the elevated risk of the cardiac event. By the elevated risk, I mean the RCI in the factors which are there, at least two factors should be present. Along with this, the patient should be undergoing the proposed surgery should be of higher cardiac risk. And if one is not able to evaluate the functional status of the patient, or if patient is reporting lower functional status less than 4, only in those conditions it is useful to go for the exercise echo or the pharmacological dobutamine stress echo.
Right. Thank you. Um, we have another question as to which inhalational agent to use in the cardiac patient. I think you have perhaps covered that.
We have agent which will cause the myocardial uh, depression, that will be halothane. And we also need to see that the the agent that is being used for the anesthesia does not cause extreme of the tachycardia, extreme of the bradycardia. So we have to use the go for the or agent. There is no difference between these agent cardiac patient.
Right. Uh, a few more questions I think we can take. Uh, just a second. What is the role of nicotinell in intraoperative MI? Dr. Sharan Jyoti wishes to know. So nicotinell is a vasodilator which is used for management of angina. So Dr. Sharan wants to know if we can use that for interoperative MI.
Uh, there are very limited evidence to support
Yes.
the role of the nicorentyl in the intraoperative MI.
Yes.
It is not advisable. It will depend on, person to person or your institutional protocol, but it has not been recommended.
So there are no clear guidelines on that. And again, with most vasodilators, you see they are a double-edged sword. Sometimes they can cause a precipitous fall in the blood pressure also, and a lot of factors have to be kept in mind when we are using such drugs intraoperatively.
Yes.
Dr. Rajni wants to know a patient has developed ST depression and requires and this urgent surgery is required. What is the decision that can be taken? Now, Rajni, I think again this becomes a rhetorical question, and a lot needs to be, uh, considered when we are taking up such a patient. The emergency of the surgery, the other factors also. Dr. Sukyanti, would you like to add on to that?
N- I think we have discussed already that regarding that we
Yes.
need to see whether how urgent is the surgery.
Yeah.
So we can, depending on the resources which are there in your setup, you can take decision upon that.
Right.
Dr. Prachi is asking if 5-lead ECG is not available, which lead combination should we prefer and why? If 5-lead ECG is not there, with the 3-lead system, various other type of the lead combination that have been there in described in your books, like the CM5 or the uh, with the 3-lead system, we can also find out the type of the ischemia that patient may sustain. Like in CM5, what we do, we take the 3-lead system and the right arm lead that is placed near the sternum. So that the axis that will cover the left ventricular axis, that will give you an indication of the ischemia. So even with the 3-lead system, we can go for the various type of the ECG monitoring, CM5, CS5, SSL, that lead combination can be produced. So it has been given in your books. You can read about that in your chapter 36 of Miller's anesthesia. There is a small paragraph on type of lead combination that can be used to detect the ischemia. It's a very small paragraph. If you want to go into the details, you can read that.
Right. Yes. Very wise suggestion. I'm sure the students will be very happy to go through that. Dr. Rajni wants to know the role of everbridin in perioperative management of heart rate. It's a good question, actually.
Uh, Ivabradine is nowadays used by the cardiologist for controlling the heart rate, but from the anesthetic point of the view, it is not very commonly used intraoperatively, because ivabradine will going to take some time to achieve the heart rate during even during the preoperative period, you can, if time is
Dr. Sukhanti, will that be fine?
yes, ma'am.
Good. Let's just take the last question here from Dr. Deepik. She wants to know what is the significance of DSE in case of a male who's more than 65 years of age of cardiac events.
That will depend surgery is posted.
Yes.
If he is posted for cataract surgery, it is useless to get DSC done. If he is proposed, we are anticipating more fluid balance, and in that condition, it is definitely going to give you better prediction of the cardiac status of the patient. But if this patient is able to tell you that I'm able to climb 2 flight of the stairs without any difficulty because any dyspnea, then it is not recommended to go for the DSC. Only if you are not able to assess the functional status of the patient and the patient is scheduled for the surgery, which is considered to be of major surgery associated with the more fluid shift, then only DSC is advisable.
Thank you, Dr. Sukhanti. I think we've crossed our time, and such a wonderful lecture, a lot of learnings from the talk today. We are very grateful to you for
Thank
having
you.
taken out
Thank
time and so much effort. And seriously, beautiful presentation. I just loved your slides. I love the way you presented. And I hope students that you had a good experience. If you still have more questions, you already have our email ID. You can log in to us. You can mail us the questions and we will definitely forward them to Dr. Sukyanti. And maybe we can answer your queries ourselves too. So thank you once again. And
thank you,
thank you,
ma'am.
dear Revati, for being an excellent technical host. And thank you, students, for joining in today.
Thank you, ma'am. Thank you, ma'am, for the wonderful session. And I also thank Bharti ma'am for joining us today. And I also thank all the trainees for joining us today. Thank you, ma'am.
Thank you. Thank you very much.